Multiple myeloma. Multiple myeloma is a plasma cell dyscrasia marked by excessive production of a monoclonal immunoglobulins. Multiple myeloma commonly presents with bone pain and anemia due to bone marrow infiltration with malignant cells. Subsequent bone demineralization can lead to hypercalcemia, which can cause constipation. Systemic manifestations, for example fatigue, are also common. Fractures can occur due to osteolytic lesions, and congestion of the glomerulus with the immunoglobulins or immunoglobulin fragments results in renal insufficiency. ESR or erythrocyte sedimentation rate is often artificially elevated due to increased viscosity of the plasma from the paraproteinemia. Urine dipstick testing may show elevated protein, but results are often normal because the protein portion of the urine dipstick primarily detects urinary albumin. The evaluation of multiple myeloma begins with serum or urine protein electrophoresis. The presence of monoclonal immunoglobulin spike, also known as M spike, is highly suggestive of the disease, but confirmation requires identification of more than 10% abnormal plasma cells on bone marrow biopsy. The diagnostic criteria for multiple myeloma includes three things. The first one is monoclonal protein in the serum or urine. The second is more than 10% clonal plasma cells in the bone marrow or soft tissue or bone plasmacytoma. The third one is an organ damage, which we have mnemonic called CRAB, C for calcium elevation, R for renal insufficiency, A for anemia, which is usually normocytic, and B for bone pain, which is usually due to lytic lesions. Let's talk about the complications of multiple myeloma. It could be due to hypercalcemia, which can be asymptomatic, or we can see the symptoms such as anorexia, nausea, polyuria, constipation, weakness, or confusion. Treatment is usually with hydration and dexamethasone. If it is mild hypercalcemia, we use dexamethasone. If it is moderate to severe hypercalcemia, we use bisphosphonates. The renal insufficiency is usually due to light chain cast nephropathy or deposition disease. Can be acute or gradual in onset. Eventual normocytic anemia due to kidney damage and may require plasmapheresis or dialysis. Infections, for example pneumonia or urinary tract infections, are usually common and high risk during it is at high risk during first 3 to 4 months of the therapy. Vaccines and prophylactic antibiotic during the therapy, which help to prevent these infections. Skeletal lesions usually present with bone pain or the pathologic fractures. Bisphosphonates for prevention is usually used. Hyperviscosity syndrome. It can usually cause nasal or oral bleeding, blurry visions, neurological symptoms like confusion or headache, heart failure, and for the symptomatic patient, the plasmapheresis is usually required. Thrombosis. It has high risk of arterial, for example stroke or transient ischemic attack, TIA, myocardial infarction, and venous thrombosis are common. Thank you.